Good morning. Today we will have two case discussions. This is a common short case entity. Patient may present with umbilical discharge in childhood period or maybe in adult also, but adult approach will be a little different. In childhood, the diagnosis are often more straightforward. So we'll have the first case and the second case both presented by Dr. Malvika Rao, who is a second year DMD resident at Apollo Hospital, Kolkata, and Professor Kalyani Basu, who is Professor of Pediatric Surgery at NS Medical College, will moderate this session. So, Dr. Malvika, you can start.
All right. Good morning, everyone. This is a case of patent Vitellointestinal duct. Next slide, please. A history: my patient is Sayan Mukherjee, a 4-month-old male who was brought by his mother at pediatric OPD of my institution. He presented with the chief complaints of intermittent green-brown discharge from the umbilicus since birth and swelling at the umbilicus since birth. Next. The informant was the mother. He was apparently all right at birth, without any complications neonatally. And he presented with intermittent foul-smelling, variable quantities of green-brown discharge from the umbilicus, which was first noticed in the second week of life after the cord separation, and gradually increasing in quantity. She also noticed the discharge was increasing when the patient was crying and resolved spontaneously. Occasionally, there was a thick, clear discharge from the umbilicus as well. She also noticed a small red-colored swelling at the umbilicus around the same time, which was sudden in onset, had not progressed in size and has not progressed in size since the beginning, and has no appreciable aggravating or relieving factors. There is no history of fever or pus discharge from the umbilicus, no history of vomiting, abdominal pain, distension, associated bowel or bladder complaints, non-passage of stool or any GI bleeding, no history of bleeding from the swelling, no history of inability to feed or inadequate weight gain or decreased activity of the baby. On past history, the baby is a product of full-term normal vaginal delivery. The birth weight was 2.7 kilos. The neonatal period was uneventful, and except this present complaint, he has no known comorbidities or past surgical history, and he is fully vaccinated till the present date. Personal history is normal bowel and bladder function, normal sleep and appetite, is adequately active, and exclusively breastfed till date, and he has no known drug allergies. Next. There is no such complaint in any other member of the family, and he's the only child to his parents. Treatment history: he received topical ointment for 4 weeks in the beginning for the umbilical swelling. There was no improvement in the symptoms. Summary: my patient is a 4-month-old baby who presented with the chief complaints of intermittent green-brown discharge and swelling in the umbilicus since birth. Both symptoms were sudden in onset, and while the discharge was progressively increasing, the swelling showed no change in size despite treatment with topical ointments. There is no increase in the discharge on crying, and has the spontaneous resolution. He has no history of trauma, fever, abdominal pain, GI bleeding, or history suggestive of bowel obstruction or failure to thrive. On general examination, I examined my patient in a private room with the mother's consent with adequate lighting and exposure. My patient is conscious, alert, and responsive to stimuli. BMI is 15.8. He is adequately hydrated. Capillary refill time is normal. Is afebrile. Pulse is 100 beats per minute. BP is 100 by 50 millimeters of mercury. Respiratory rate is 24. There is no pallor, edema, lymphadenopathy, icterus, sinuses. On abdominal examination. On inspection, the abdomen is flat, umbilicus is inverted and well centralized. There is a solitary red swelling at the umbilicus, small amount of mucoid discharge around the umbilicus, which I will go into detail later. All quadrants of the abdomen are moving equally with respiration. There is no scars, dilated veins, or peristalsis over the abdomen. Hernial sites appear to be normal, and external genitalia appears to be normal. Next slide, please. On palpation, temperature over the all quadrants of the abdomen is normal. All inspectory findings were confirmed. The abdomen is soft, non-tender, non-distended. There is no appreciable organomegaly or palpable lumps other than at the umbilicus. Local examination of the umbilicus. There is a single red-colored mass at the umbilicus, 1 centimeter by 1 centimeter in size, which appears to be lined by mucosa on the surface. It is a non-tender, soft, smooth, sessile mass with well-defined margins and edges. It is non-pulsatile, non-expansile, non-transoluminant. Cough impulse could not be elicited if the patient remained calm during the course of the examination. Surrounding skin appears to be normal and is stained by a thin layer of mucoid discharge. There is also a foul-smelling green-brown discharge coming from the umbilicus by the side of the mass with air bubbles, which increases on pressing the upper abdomen of the baby, which is the discharge is most likely stool. On percussion, there's a tympanic node over the abdomen, liver and spleen. On auscultation, peristaltic sounds are normal. Systemic examination is essentially normal. My provisional diagnosis is that this is the case of fecal fistula and umbilical polyp in a 4-month-old full-term baby, most likely due to a patent vitellointestinal duct.
Dr. Malavika, will you please elaborate when the cord separated, the child was delivered by normal vaginal delivery? Was it an institutional delivery?
Yes, ma'am.
And what was used to tie the umbilical cord? Was there any liga clip issue used, or was the delivery conducted by a trained eye or
the
sister
delivery
on
was
duty?
in the hospital itself.
Baby was delivered at Apollo.
In this patient, birth history is important. You should give little more about the madam is asking about the birth history. What are the confinement is done where? How was the umbilical cord tied? At what time umbilical cord separated?
Okay.
She was fine 4 months down the line. So any problem immediately after the cord separated out?
The cord separated out on the 7th day of life. I'm not sure about what was used to tie the umbilicus at the time of delivery.
This is a very important history in this part. Many times it happens that there is an associated, oxymphalos minor or hernia of the umbilical cord, and if it is tied too close to the abdominal parietes, there might be some acquired fecal fistula than patent VI. So this is a very important issue, that before you tie the umbilical cord, it should be at least 8 to 10 inches away from the abdominal parietes, and before that you milk down all the contents towards the baby. I have seen such cases happening, that the clamp was applied too close to a hernia of the umbilical cord, and this fistula is actually acquired. Anyway, I hope nothing of that sort has been happened, but you must elicit this history.
Okay.
And regarding your examination part, I think blood pressure in babies and infants, it is less than adult. So you must not fib. If you haven't examined, tell them you haven't examined. It is unlikely that a 4-month-old baby, usually normal blood pressure at this age group is 70 by 50, not 90 by 50. If it is 100, then the baby is hypertensive. The questions will go to that side, so you don't do that. Most of the times it happens that the proper cuff, appropriate blood pressure measuring cuff is not available. You tell that appropriate cuff was not available, I could not measure blood pressure. And the baby is 4 months old, so your history, even though it's a short case, it should include the fontanelle and head circumference.
Okay.
So how will you manage the case?
I would like to do a couple of investigations to confirm my diagnosis. For this case, I will do a fistulogram to assess the length of, to fistulogram and abdominal imaging, and then I will do some basic investigations, blood investigations like complete blood, routine blood investigations to prepare the patient for surgery, because that will be the treatment of choice, which is complete blood count, urea, creatinine, electrolytes, coagulation profile, and
While you, your answer is, I'm not saying it's wrong, you clarify these ways that my investigations for confirming the diagnosis and investigations pertaining to preparation of the patient for surgery will go side by side. And for confirmation of diagnosis, the first investigation should be ultrasonography, because USG these days is not available, is available in every ward, and the residents are supposed to know how to perform an USG. So for ultrasonography of the abdomen to find out if there is any other solid viscous anomaly, as well as ultrasonography with a high resolution probe, they can show the underlying communication, the cord-like structure which extends to the peritoneal cavity or is attached to the bowel. Usually they can show it. Then comes the fistulogram. The answer is not wrong, just you have to change the order. Okay.
okay.
And in the history also, even though your discharge is clearly greenish, most like this stool, even though you should ask mother whether the baby passes urine in good projectile stream, especially baby is a male baby.
Yes, ma'am.
A good projectile stream, and at no point the discharge is urine-like, or there is no uriniferous odor. This should be mentioned in the examination, because you never know, it may be patent VID, it may be patent Urachal. So exclusion, this is an important history which should be excluded.
Okay.
Then how do you do? What do you do?
Once I have confirmed my
Have you
diagnosis.
done the fistulogram? Is it available with you?
No, ma'am, I don't have the fistulogram.
Oh, then how do you manage the case?
Once I've confirmed my diagnosis, and I prepared my patient for surgery and counseled the patient about the condition, a patient's family about the condition, etc. I will, and the mode of treatment, I will plan total umbilectomy with an umbilectomy with excision of the patent Vitellointestinal duct, and wedge resection of the ileum with end-to-end anastomosis.
And what about the reconstruction there? You have excised the umbilicus. It is very vital for the patients and the family that the umbilicus, there should be a normal umbilicus. So umbilicoplasty. And wedge excision is no longer recommended because most of the time it fades. There is a apical fistula once again. So it's better to perform end-to-end resection and then anastomosis. And what type of incision will you use for this patient?
Ma'am, the approach incision will be it's a elliptical incision around the umbilicus, ma'am.
Usually you go one circumference of the umbilicus. We prefer transverse incision because the transverse scar is very minimal, but you can go midline. You expect your communication will be towards the right iliac fossa or in the midline. So it's no point going towards downwards. You can extend the incision a little bit upwards. And umbilicoplasty, how is umbilicoplasty done?
Umbilicoplasty can be done by what we do is superiorly we take a rectangular fold of skin, and which is made into a tubular structure, and the base of that is attached to the rectus sheath, and the skin is closed into fashion a new umbilicus.
Is there any role of laparoscopy? Can you do it laparoscopically, minimally invasive surgery?
For umbilical repair?
No.
Yes. For the excision of the patent VID?
Ma'am, it can be laparoscopic assisted, but to identify any other intra-abdominal pathology, but laparoscopic there's no.
Why not? The God has already made your port, isn't it so? Has made your optical port. So you put in the way you perform an optical port in all other cases, since you'll have to go through the infra-umbilical approach. And then you identify the patent VID, and through that incision, if you are not conversant with performing the anastomosis in situ, you just spend the bowel prolapse to that and do the repair and put it back. But you can easily use it at most many a times. Now this case is for having clear fecal discharge. If this is no clear fecal discharge, to exclude the presence of abdominal communication or not, you put in an optical port, find out where is the communication. Many of the time it's only a fibrous cord. That excision can easily be done through laparoscopy. You may not need the resection anastomosis.
Okay.
So what other possibilities, I mean, remnants of patent VID can be there?
Okay. Ma'am, one is the patent Vitellointestinal duct, which is the rarest of the cause. The most common is Meckel's diverticulum, which is a true diverticulum from the ileum. There can be a complete fibrous cord. There can be an fibrous band. There can be an enterocystoma, where there is degeneration of the proximal and distal part of the Vitellointestinal duct, and only the mid part gets dilated and forms a cyst.
There can be prolapse of both proximal and distal ileum through the patent VID also. Many a times two horn-like structures coming out from the umbilicus.
Yes, ma'am. And the last one is umbilical polyp or raspberry tumor, where there is only the distal part of the Vitellointestinal duct remains patent, and the mucosa gets prolapsed and forms a small mass.
What are the common presentations of a Meckel's diverticulum?
Meckel's diverticulum can be asymptomatic, which is the most or incidentally found. The most
What
common
percentage of cases?
98%, ma'am. Only 22% are symptomatic.
Suppose you are performing appendicectomy and there is a Meckel's diverticulum. What will you do?
If we're performing an appendicectomy and the appendix is pathological, then we will leave the Meckel's diverticulum alone. If the appendix is not pathological, then we will trace the ileum up to the Meckel's diverticulum and try to find the source of, if that is the source of pathology.
Can there be adhesive obstruction because the Meckel's diverticulum is attached to the umbilicus with a fibrous cord?
Yes.
So bowel loops can go around it and form
cause
adhesive obstruction, stricture formation. And what other presentation?
Can present with Meckel's diverticulitis with abdominal pain and
bleeding per rectum, and
bleeding per
it can serve as a point for interception also.
Yes, ma'am. Interception. Yes. Interception. It can cause intestinal obstruction.
How do you diagnose Meckel's diverticulum? The bleeding is from Meckel's diverticulum. A particular investigation is there for this.
Yes, ma'am. It's called the Meckel's scan, or it's called the technetium scan, where technetium 99 is given intravenously, and then we take serial radiographic images of the baby in supine, lateral, and supine and lateral position from anteriorly and posteriorly.
Is seen as what? Cold spot or hot spot?
Seen as a hot spot, sir.
There's another scan which is gallium level RBC scan. That if the rate of bleeding is more than 0.05 ml per second, then it can detect an actively bleeding Meckel's diverticulum. Most of the technetium level scans, Meckel's scan, the pickup rate is rather low.
Yes, ma'am. And they have also high false positivity rate, especially when there is GI bleeding associated. They have only 60% sensitivity.
What is the source of bleeding in Meckel's diverticulum?
The source of bleeding in Meckel's diverticulum is the gastric mucosa in the Meckel's diverticulum, which is ectopic gastric mucosa, heterotopic gastric mucosa.
Where is the ulcer? Ectopic gastric mucosa is in the Meckel's diverticulum. Where is the ulcer? On the opposite circumference of the Meckel's diverticulum. So ileal mucosa is not adept for gastric secretion. So there is ulceration, bleeding, perforation. Okay. Dr. Shah, you want to ask?
Yes, I think you have discussed the whole part. Basically, you should be What is exactly the VID? Vitellointestinal duct is what at embryonic life.
Sir, it's the communication between the yolk sac and the primitive alimentary canal at the time of.
It's a diverticulum from the midgut to the primitive yolk sac,
Yes,
which goes through the umbilicus. That is a vitellointestinal duct.
Initially, the embryo is a flat striatum structure which is floating into the yolk sac. Then the embryo folds on itself, and a part of the yolk sac is incorporated within its folds. That forms the alimentary tract, and the communication persists throughout. So that forms the vitellointestinal duct. Throughout the mid-trimester, it persists.
Okay.
Proceed with your next case.
This is the case of Urachal fistula. The patient is a 5-year-old male, resident of Howrah as a student. Came with his mother to the pediatric OPD. History was given by his mother. He presented with the chief complaints of poor urinary streams for the past 1 year, watery discharge from the umbilicus for the past 7 months, and rash around the umbilicus for the past 3 months. Next slide, please. According to his mother, the child was apparently all right 1 year ago, and he developed gradual onset poor urinary stream with swelling of the prepuce during foreskin during urination and inability to retract the foreskin completely. They consulted a local surgeon who diagnosed him with chronic balanopostitis, and he underwent circumcision. Postoperative period was uneventful, and he was discharged. But he continued to experience poor urinary stream even after the surgery, which has progressively worsened. 7 months ago, he noticed his mother noticed an unexplained wetness around the umbilicus while she was dressing him for school. Over time, it developed into a larger amount of watery discharge, which was soiling his clothes and left a characteristic urine-like smell. The discharge was nearly continuous and gradually increasing in quantity. He would require to change his clothes around twice a day 6 months ago, and now he needs to change his clothes around 4 or 5 times in order to be presentable. 3 months ago, he started complaining to his mother about burning pain around the umbilicus, and she noticed a reddish rash over the umbilicus and surrounding skin. The rash was gradual in onset and progressed in size to attain the current size, which is around 3 by 4 centimeters. The burning sensation was partially relieved when application of talcum powder and on cold compress. There is no history of trauma or any surgical intervention in the abdomen. No history of fever, pain in abdomen, burning micturition, pus or feculent discharge from the umbilicus. There is no history of abdominal distension, lump in the abdomen, weight loss or fatigue, and no history of rectal bleeding. No history of rash in any other part of the body or exposure to any known allergens or change of routine personal hygiene products. On past history, there are no known medical comorbidities. He underwent circumcision for phimosis due to chronic balanopostitis 1 year ago. There are no known drug allergies and no similar complaints in the past. Personal history is a poor urinary stream since the past year. He has normal bowel habits. Sleep and appetite is normal. He is a product of full-term normal vaginal delivery and is 3 kilos at birth. Family history is not significant. My summary. Patient is a 5-year-old male who came with the chief complaints of poor urinary stream since 1 year, which persisted even after circumcision, which was done for phimosis and which is gradual in onset and progressive. He also has a watery discharge from the umbilicus with a characteristic uriniferous smell and gradual in onset and progressive in nature for the past 7 months. 3 months ago, he developed a rash over the lower central abdomen, which was also gradual in onset and progressive in nature. There is no history of fever, pain in the abdomen, any distension or abdominal lump, or rash in any other body or exposure to known allergens.
finish up.
Before you proceed to your general examination, I'll ask several questions which are important from the history.
Yes.
This is from your history, I could gather that this patient has got only 1 year, 5-year-old, and 1 year, for last 1 year is having poor urinary stream. You'll have to clarify the urinary stream. Like, is he having difficulty in starting the initiation of urination, or there is prolongation of the period through which is processed urine, or if there is any post-void dribbling, or if he dribbles intermittent, like he changes his garments, but there is constant wetness of his garments or not. And how far projectile, its best thing is to observe, ask the baby, 5-year-old, we can follow your command, ask the baby to pass urine and find out the stream. And at this point, you will have to elaborate the birth history a little, like the antenatal period. Did the mother undergo any antenatal ultrasonography examination? And was there any abnormality detected in the fetus? That is important. And second, whether the mother had any oligohydramnios. How do you get, most of the time, antenatal USG is done, but it is not available. But you have to ask the mother. If she has any other child, you'll have to ask, was your abdomen as protuberant as it was during other pregnancies? Or people used to find it hard to believe that you are pregnant because your abdomen protuberance was so small. And whether there is any history of birth asphyxia, because if the patient has got any bladder outflow obstruction, then the patient will present and will need essential treatment. After birth, there was any difficulty in breathing, patient was not taking respiration and needed essential support. These are the few points which you will have to find out from the history. Okay, you proceed with your examination.
Okay, ma'am. On examination, I examined patient in a private room after taking consent from his mother. There was adequate natural light, and I exposed my patient child from mid-chest to mid-thigh level for the purpose of examination. He was conscious, alert, and cooperative. BMI 16.3. Is afebrile. Pulse is 96 beats per minute. BP is 110/70, and respiratory rate is 18. There's no pallor, icterus, cyanosis, clubbing, patternopathy, or edema. On inspection, the abdomen is scaphoid, umbilicus is inverted and well centralized. There's wetness in the periumbilical and hypogastric region, which is present with, and there is an erythematous rash that is present, which I will describe in later. All quadrants of the abdomen are moving equally with respiration. There's no obvious lump or deformity. No scars, dilated veins, or peristalsis over the abdomen. Hernial sites appear normal. External gelatiria appears to be normal on inspection. On palpation, temperature over all quadrants of the abdomen is normal. All inspectory findings were confirmed. The abdomen is soft, non-tender, non-distended. There is no appreciable organomegaly or palpable lumps. Local examination of the umbilicus. The umbilicus is well centralized and inverted. There is wetness over the periumbilical and hypogastric region with a strong ammoniacal smell from the region. There is also focal skin excoriation in the periumbilical region, which is approximately 4 centimeter to 3 centimeter in size. In the examination of the external genitalia, the scrotum, shaft of penis, and glands appear to be normal. Prepuce is absent, and there appears to be an urethral meatal stenosis with some signs of perimeatal fibrosis. Percussion tympanitic note over the abdomen, auscultation, peristaltic sounds are normal, and systemic examination is normal. Provisional diagnosis, case of urinary fistula with urethral meatal stricture and periumbilical and hypogastric skin excoriation in a 5-year-old male, most likely due to urethral fistula.
How do you explain the urethral meatal stricture?
Chronic balanoposthitis was there, and maybe because of the recurrent inflammation, he can have developed urethral meatus stricture as well, which was missed probably during the primary, the first circumcision. The first circumcision.
So this child is 5-year-old. Usually post-circumcision urethral meatus stricture happens in newborns and infants who are put into diaper. After circumcision, you put the baby in diaper, there is ammoniacal dermatitis which causes stricture. And this child can have urethral meatus stricture, as you said, due to meatal stenosis. How do you exclude? Due to velanoposthitis. This, if there is velanoposthitis xerotica, it might include the urethral, whole of urethra becomes fibrous, stenotic, and will require urethral calibration and dilatation. So it is a good practice after circumcision. You calibrate. If you don't have any dilators, no issue. You just put in an infant feeding tube appropriate for the child's size and exclude there is any stricture or not. And if there is some inclination towards that, then you advise regular urethral dilatation using either fully formed bougies or infant feeding tube with some steroid application. This point is very vital. And when should you perform circumcision? This is a very common practice. Any child with bladder outflow obstruction, we see that they perform a circumcision thinking that it will improve. It's due to the velanoposthitis and fibrosis, but it does not. So what is the ideal age for circumcision?
In case of chronic velanoposthitis?
No, can there be any phimosis since birth? When will you call it phimosis?
I don't know.
Up to 2 years of age, the normal redundant skin and prepuce adherent to the glands is normal. Separation of the prepuce from the glands occurs by smegmal collection under the prepuce, and that lifts up the skin. So if the external urethral meatus is visible by gently retracting the prepuce in a neonate, in an infant, this is no phimosis. This is congenitally adherent prepuce. So before 2 years of age, any child presenting with a long prepuce, which mother says that it balloons up during urination, that is actually how it separates. So you just have to clean the meatus with some lotion or under running water and using a Johnson's butt, but do not perform circumcision before 2 years of age, unless there is a history of repeated urinary tract infection.
Okay.
So even it may take complete separation up to the glands, may take even up to 4 to 5 years. So do not jump for, unless there is a religious indication, like or these days even they ask doctors to perform circumcision for religious reasons. But otherwise, medically speaking, unless the patient has repeated history of urinary tract infection, then also you exclude other forms of bladder outflow obstruction before jumping to circumcision.
Okay.
Proceed with your provisional diagnosis. This is a case of
Urinary fistula with urethral meatus stricture and periumbilical and hypogastric skin excoriation in a 5-year-old male, most likely due to urachal fistula.
how do you proceed with management of the patient?
I would like to confirm my diagnosis and simultaneously prepare the patient for surgery. I would like to do a mixture voiding cystourethrogram.
No, Malvika, don't forget, ultrasound is always an extension of clinical examination. Now, ultrasound is
almost
part of
a clinical examination now. Your machine is available in your examination book.
So don't forget, ultrasound is a non-invasive investigation that helps the clinician, and even surgery resident can do it. So always should be ultrasound. But it a lot of information because a urinary anomaly may have some other associated anomaly that you cannot make out by a fistulogram. So ultrasound should be the basic investigation.
All right. I will do an ultrasound of the whole abdomen. I will also do exclude bladder outlet obstruction and other anomalies in the urinary tract. I will do a voiding cystourethrogram.
Elaborate on the ultrasonography part. Why are you jumping?
Oh, ultrasonography to assess the kidneys, the ureters, if there's any hydronephrosis or hydroureteronephrosis in the condition of the bladder, the post-voiding urine
Residual urine.
residue.
What will be the condition of the bladder if there is bladder outflow obstruction? Ultrasonographic features.
It will be distended. There will be distension, thinning of the wall of the bladder.
No, for 5 years, the bladder is trying to circumvent the obstruction. So there will be muscular hypertrophy. The bladder will be thick walled, very thick walled. So bladder wall thickness is important.
Yeah.
And
Bilateral hydroureteral process. And anything else?
it
Can you
will
diagnose posterior valve by doing ultrasonography? Can you have a suggestion that this patient might have posterior valve?
posterior. I don't know, sir.
No, it cannot be
Perform
done.
the ultrasonography of the perineum with a special probe, and you can find the posterior. If the posterior urethra is roomy and dilated, there is a constriction at bladder neck. Then the posterior urethra is roomy and dilated, and then there will be the position of the valve at the level of the valve. So that thing presents as a keyhole sign on ultrasonography, even if it is visible in antenatal USG also. So you perform the. For a 5-year-old child with proper consent, you can use an endorectal probe also. But you can diagnose by posterior valve by ultrasonography itself. But of course, for medical legal purposes, you will have to go for voiding cystourethrogram. She is jumping a lot for voiding cystourethrogram. So what are the prerequisites for performing voiding? It's an invasive investigation. And mind you, it can produce a lot of complications. So tell me, what are the preparations which you will do for voiding cystourethrogram?
I don't know. I'm sorry.
So first you perform a routine urine examination as well as culture. Urine should be sterile before you put in a catheter. And especially for heaven's sake, in neonates, infants, you admit, keep the patient under observation, document that your urine is sterile, and then you perform the micturating cystourethrogram under antibiotic coverage. But if you are performing in a 5-year-old child under all strict aseptic and antiseptic precautions, then you do not need to put in any antibiotic. Okay. Any idea how to perform voiding cystourethrogram? Okay. It's usually the pediatric surgery residents who are supposed to know. One point I told you, that urine must be sterile, bowel must be clear, you must make a bowel preparation. And when you pass in a small size infant feeding tube, not a snugly fitting catheter. And just as soon as the urine starts coming out, you can measure the urinary volume that is in the bladder. So that way you can have an assessment whether the bladder is accumulating more urine than it should. And then you put in a 1:1 dilution of the urographene with sterile normal saline. And usually there is a formula. I am not going into detail of that, how to calculate bladder volume. But usually you keep on injecting till there is a pericatheter leakage. And at that time you take the film. It's best done under video cystography, and that will show you. And another instruction is very important. Since it's a cystogram, the radiographers do not include the renal area. So the renal area should be included to demonstrate
Reflux.
what happens. Reflux. Aapka sir is answering for you. To demonstrate vesico-ureteric reflux. So these are the 3-4 points which you must answer regarding voiding cystourethrogram.
Madam, can it be a continuation of IVU? After IVU and the bladder is full, then patient is asked to pass urine. Because you want to access the upper tract also.
All of the dye will not go away. It can be a continuation of the isotope renogram, DTPA renogram, that can show reflux, a continuation of that, but the radiation dosage is very high. Okay. So in that, it is better to, even for voiding cystourethrogram can be of several types. It can be with dye, it can be nature field cystography, that is how the patient is forming urine and passing it, and it can be radionuclide cystourethrogram, where you instill the radionuclide dye demonstrate if there is any reflux and drain it out. That way the radiation dosage is much less than that as a continuation study of PTP. Okay, then what else will you perform for this patient?
I will also do routine investigations, routine blood investigations, urine culture sensitivity, and in blood investigations, complete blood count, urea creatinine, serum electrolytes.
Which electrolytes? Your patient might be having bladder outflow obstruction. Urea creatinine may not be normal, may not be abnormal. The patient is maintaining for last 5 years. So whatever renal reserve he has got is sufficient for him now, but he will go into end-stage renal disease once his growth spurt starts occurring. So there are few specific investigations which can tell you whether renal damage can occur or not. So what are those? Apollo people are very particular about all these investigations, especially Dr. Devashish Mitro and other people who are working there, advocate it, I know. So you must be aware of that. Are you? Microalbuminuria or albumin creatinine ratio. Okay. And urinary sodium, potassium, and chloride. Analysis in 24 hours urine sample. And another thing is there, like especially regarding electrolytes, you'll also have to take notice of calcium and phosphate level. Sodium, chloride, calcium, and phosphate. Okay. If there is any bladder outflow obstruction, how come the patient is presenting so late? Why is it not since birth?
Ma'am, the patient developed urethral stenosis, urethral stricture only in the past 1 year. So only after that he started developing symptoms of bladder outflow obstruction and urethral urine leakage.
Not usually telling a child who's expelling urine through his patent urachus did not have any bladder outflow obstruction beforehand is unlikely. Sure, the urinary stream was poor at that phase also. You mentioned BMI, but I would really like to find out actual height and weight of the child. Is it at par with that of his age? Is it appropriate?
Yes, ma'am. It's appropriate for age, yes, ma'am. I don't remember the exact values, but it's appropriate for well developed.
In your examination, you did not mention the spine. It is very important. This patient might be having a neurogenic blood. There might be spine. You will have to inspect the whole of the spine and palpate. There might be some lumbosacral anomaly causing neurogenic bladder and bladder outflow obstruction. Because patent urachus is much less common than patent VI. So what will you perform? How will you manage? You have performed investigations. What will you do?
Ma'am, I will do an umbilicectomy with an excision.
No, dear, you must
What about obstruction?
Diagnostic cystoscopy. Before you go do anything with the patent urachus, diagnostic cystoscopy is a must. You should not omit. Okay? What are the things that is expected in a diagnostic cystoscopy? If the bladder is normal, if the bladder has got posterior rectal valve, bladder flow obstruction, and if the bladder has got neurogenic bladder. Things you'll have to learn. Did you have urology posting?
No, not yet.
Oh, okay. Tell me, what are the cystoscopic findings of a normal bladder?
The normal bladder, the urethral and the posterior, it is not really posterior rectal valve. In males, there will be
There are two methods of performing this can be urethrocystoscopy. That is, by putting the scope, you examine the urethra and proceed, or it can be cystourethroskopy. That is, you first go into the bladder and then you come out of it. So describe a normal bladder appearance on cystoscope.
The mucosa is salmon pink. The trigone of the bladder will be clearly slightly raised, and the both
once you cross the bladder neck, you try to identify the ureteric ridge.
Yes.
interureteric bar of tissue, and go to the 3 o'clock and 9 o'clock position to find out the ureteric orifices, which are usually slit-like, and it opens when a stream of urine comes out. If the ureteric orifices are abnormal, if it is crater-like, stadium-like, or a volcano-like, there might be associated vesicoureteric reflux. And if there is a bladder outflow obstruction, then the bladder mucosa will be congested, hyperemic, there will be trabeculations. There may be associated saculations also. And if you go towards the roof, you can find out the opening of your patent urachus also. And in case of neurogenic bladder, the bladder neck is wide open. So you can demonstrate that. As I said earlier, during posterior urethral valve, the posterior urethra is roomy. Pujor moton dekhte. It's like a pitcher-like thing, very roomy. The veru is prominent and two thin whitish valve clasps which resembles boro boro macher ash যেমন হয়, large fish scales. It may be very vascular reddish also, not always white, proceeding from the veru downwards in 7 o'clock and 5 o'clock position. A little lower down, it unites at 12 o'clock position. So that is the posterior urethral valve appearance on cystoscopy. So you will deal with the patent urachus only when you have excluded your bladder outflow obstruction, if there is any or not. And if there is bladder outflow obstruction, you do a valve fulguration at 5, 7, and 12 o'clock position. And at the same time, you excise the urachus, close the bladder in layers, mucosa with absorbable catgut, muscles with delayed absorbable PDS or vitri, and put in a drain in the sub-umbilical region after performing umbilicoplasty. Until and unless you do not deal with the bladder outflow obstruction part, there will be a recurrence of the fistula. It will not heal. Suppose this patient has got associated neurogenic bladder. What other investigations will you like to perform? Patient may not have any other symptoms like trophic ulcers, weakness of limbs. What other investigations will you like to perform? X-ray lumbosacral spine. That will give you an idea whether if there is hemivertebra or any spina bifida, and you definitely go for MRI spine. And if there is no tethered cord, any other thing, only neurogenic bladder, what is the treatment?
My medical management for neurogenic bladder.
Clean intermittent catheterization. This technique has revolutionized and has been able to give neurogenic bladder patients preserved renal functions if it is performed in the way it should be, maintaining all hand washing, clean catheter, that they can have a good life for a very long time. So clean intermittent catheterization. For most of the cases, neurogenic bladder do not need any surgical treatment unless the bladder is very small, autonomous with poor storage. I don't want to go into the details of that. So for your patient, you do a diagnostic cystoscopy, rule out bladder outflow obstruction, and then you excise the patent urachus, close the bladder. Will you maintain an SPC for this patient while closing the bladder?
No, ma'am, because I will be dilating the urethra in the same city.
While you are closing the bladder, keep at least a periurethral catheter. Okay.
Urethral catheter, yes.
Periurethral catheter at least for 7 days. Okay. And you give a trial, like keep the catheter closed after 7 days for 2 to 3 hours and ask the patient to pass urine peri-catheter. Then you remove it. Many a times these patients will go into repeat retention in urine, will require further catheterization. And then there is the manipulation of using drugs. What are the drugs that you use if patient has got post-catheter removal voiding difficulty? You are getting into very deeper waters. In examination, be very careful. Don't utter medical manipulation. And there is very few studies, especially in children's age group, regarding drugs. In adults, there are many drugs in use, but children usually not. So be very, unless you are very sure that you know what are the drugs used. Any idea?
No, ma'am.
Oxybutine. First you use oxygen, that it reduces the bladder spasm. It is available as Tropan for a 5-year-old child. They will need 5 milligrams, and usually it's a prolonged therapy. And these children have to have a baseline video urodynamics before you start any medical manipulation.
What is urachal cyst, Malavika?
I'm sorry.
What is urachal cyst?
Urachal cyst is when the proximal and distal portion of the urachus is obliterated, only the mid portion of the urachus is patent. So that presents as a lump in the hypogastric region, which may get infected secondarily and cause symptoms. It becomes
formation, pain, redness. Somebody might drain it as an abscess, but later on there will be the non-healing sinus. So you'll have to do a subumbilical incision and excise urachal cyst.
Yeah. So I think we have almost covered the whole aspect of patent VID, and Malavika has presented very well. She is doing well.
Yes, good presentation, but Malavika, one thing I would like to tell you, the examination is more like a game of chess. You'll have to, I'm not much of an examiner, sir is. So whatever move you make, the examiner jumps at it. So don't make any move unless you are certain of it. With a superficial knowledge kind of thing, if you haven't read about it, just don't make any guesswork. So you can lead your examiner towards the path in which you are very conversant and very confident. Try practicing that.
Yes.
So, thank you. All the best for your exam. Thank you, Professor Shah. Thank you.
Thank you, madam. Thank you for joining.
Thank you, ma'am.
And I thank once again for giving me an opportunity to be present in your class.
We are so grateful that you are joining for the DNB students.
No, I like
Because
it.
so long they did not have a structured program. So I tried to create a structured program with help of all faculties. So I must thank you, madam. Thank you.
Thank you. Thanks, sir.
Thank you.